This short presentation is going to introduce you to the concept of acid-base balance and the basics of blood gas analysis. At the end of the session, you'll be able to describe the principles of acid-base balance, apply a systematic approach to blood gases, and diagnose the common blood gas abnormalities. Before we look at the blood gas, let's quickly review how the body maintains its acid-base equilibrium. Most enzymes in the body work within a very narrow range of pH or acid-base balance. This usually is between 7.35 and 7.45. There are two main systems which maintain this equilibrium: the lungs or the respiratory system, and the kidneys or the metabolic system. CO2 dissolved in our blood produces carbonic acid and therefore acidifies the blood and the metabolic environment. By altering the way we breathe, we can either increase the amount of CO2 we blow off or reduce it. This tends to be a fairly rapid way of shifting the pH, although it is not very complete. On the other hand, the kidneys are responsible for getting rid of any excess hydrogen ions produced during the metabolic activity of the body, and can also directly produce bicarbonate. By getting rid of the acid or producing more or less bicarbonate, the kidneys can also regulate the pH of the body. This system is slow at act but tends to be more complete. With this in mind, let's look at how we can interpret the acid-base balance in the body using our blood gas sample. We're going to talk ourselves through a few simple blood gases using this systematic approach. We're going to start by asking, what is the pH? A pH of less than 7.35 is considered acidosis, whereas a pH of more than 7.45 is considered alkalosis. Once we understand whether the patient is acidotic or alkalotic, we can then move to try to determine what is the primary cause of this. So, bearing in mind from the last slide, the primary cause could be either respiratory or metabolic. Therefore, the next two things we're going to do is look at the PCO2, the respiratory component, and the bicarbonate, the metabolic component. A low pH with a high PCO2 will tell us that this is a respiratory acidosis, whereas a high pH with a low PCO2 indicates a respiratory alkalosis. On the metabolic side, a low pH with a low bicarb is a metabolic acidosis, whereas a high pH with a high bicarb is a metabolic acidosis. So what we're going to do is look at the pH and then look at the CO2 and bicarb and see which one is moving in the direction to cause the pH that we are looking at. For example, if we see a pH below 7.3 and the PCO2 is high, that's a respiratory acidosis. If we see the same pH of, say, 7.2 and we see a low bicarb, that's a metabolic acidosis. The other thing in the arterial blood gas is the PO2. We're not going to go into great detail about the PO2, just to say we will do another lecture looking at oxygenation, but really remember that the PO2 is related to the FiO2. The last thing we look at is compensation. If we have a primary respiratory acidosis, for example, the metabolic side of things is going to try to adjust us back to our normal pH or compensate. So if we have a high PCO2 causing an acidosis, the body can retain more bicarbonate to produce a relative metabolic alkalosis to compensate for the respiratory acidosis. Conversely, if we have a low pH due to a low bicarbonate, which is a metabolic acidosis, the respiratory side of the system can compensate by trying to breathe faster, blow off CO2, produce a low PCO2, and a relative respiratory alkalosis, which would move in the opposite direction to the metabolic acidosis and push the pH back towards normal. This slide takes us through the common different blood gas pictures that we see. Starting on the left hand side, we have a metabolic acidosis with a low bicarbonate and a negative base excess. If the PCO2 is normal, there is no compensation. If the PCO2 is low, that suggests that while we have a metabolic acidosis, we have a respiratory compensation. If the PCO2 is high, that means we have both a metabolic and a respiratory acidosis. If the patient is acidotic but the PCO2 is high, we then have a respiratory acidosis. So then we look at the metabolic component. If the base excess is normal, there is no compensation. If the base excess is positive or the bicarbonate levels are high, then we are producing a metabolic alkalosis in response to our respiratory acidosis, and therefore that is metabolic compensation. If the base excess is negative or the bicarbonate level is low, then not only do we have a respiratory acidosis, we also have a metabolic acidosis. If we now move to the alkalotic patients, if we have a metabolic alkalosis, which is to say the bicarbonate is high and the pH is high, then we look towards the PCO2. If it's normal, there is no compensation. If it is high, it means we're producing a respiratory acidosis in response to our metabolic alkalosis, and that is compensation. Whereas if the PCO2 is also low, we have a metabolic alkalosis, but now we're producing a respiratory alkalosis as well, so that's a combined alkalosis. Finally, if we have a low PCO2, that suggests a respiratory alkalosis. So the pH is high, the PCO2 is low. That's a respiratory alkalosis. Let's look at the base excess. If it's normal, there's no compensation. If the base excess is negative or the bicarbonate is low, then we have a metabolic acidosis in response to our respiratory alkalosis. If the base excess is positive, then not only do we have a respiratory alkalosis, we also have a metabolic alkalosis, so a mixed respiratory and metabolic alkalosis. We are not going to go into interpretation of the PO2 in this lecture. Suffice it to say that the PO2 level depends on the percentage of inhaled oxygen. We will go into this in much more detail in a subsequent lecture. One other principle to think about is the anion gap. So when we have a metabolic acidosis, this could be due to intrinsic acid or extrinsic acid. In either case, it could be due to accumulation of other acids apart from carbonic acid, and that is called an increased anion gap metabolic acidosis. Here, this is how we calculate the anion gap to see if the acidosis is a normal anion gap or increased anion gap. And these are some of the common causes of an increased anion gap. Two common endogenous causes would be lactic or ketoacidosis. Exogenous causes include alcohols, salicylates, and other poisons. So let's look at 4 simple cases and work through them using the system we described earlier. An 18-year-old patient with vomiting, lethargy, and dehydration. So what's her pH? pH is 7.05, that's an acidosis. Is that explained by the respiratory component? Well, the PCO2 is low. Bear in mind, if this was a respiratory acidosis, the PCO2 would be high. So this is not a respiratory acidosis. Therefore, let's look at the bicarb. The bicarb is low, the base excess is negative. That would fit with a metabolic acidosis. So now we've discovered this patient has a primary metabolic acidosis. Let's go back to the PCO2. Let's go back to the PCO2. So the PCO2 is low. A low PCO2 should produce an alkalosis, but the patient is acidotic. We know the patient is acidotic because of the metabolic component. Therefore, the low PCO2 is a compensation. The respiratory system is trying to push the pH back towards normal. Before we leave this slide, let's have a quick peep at the electrolytes. The most important thing here is that the glucose is very high. That gives us a little clue of what might be going on. So we've got a patient with a metabolic acidosis and respiratory compensation. If we had worked it out, we'd see that there's an increased anion gap. That would fit with diabetic ketoacidosis. Let's try another one. An 84-year-old man with bronchitis, increased shortness of breath and fever. The pH is low. He has an acidosis. Let's figure out if this is respiratory or metabolic. Look at the PCO2. PCO2 is very high. A high PCO2 in a patient who is acidotic suggests that there is a primary respiratory acidosis. Look at the bicarb. The bicarb is also very high. Bear in mind, a high bicarb pushes us towards alkalosis, so that is moving in the opposite direction to the respiratory component. We know that the pH was low, PCO2 high, so the patient had a primary respiratory acidosis. The bicarb is compensating for that and trying to correct things and make the patient push the patient's pH back to normal. The patient has an increased work of breathing, low PO2, is confused and lethargic. This patient's picture would fit with acute on chronic respiratory failure, and one of the treatments for this may be CPAP. Because the metabolic component corrects slowly but completely, you will have patients who retain CO2 and yet their pH is pretty normal because of the metabolic compensation being almost complete. The third case is a 23-year-old female who took an overdose. pH is high, she's alkalotic. The PCO2 is low, which fits with a high pH. She has a respiratory alkalosis. Now we turn our attention to the bicarb. The bicarb is a little low. Remember, a low bicarb would push us towards acidosis. A low bicarb would fit with metabolic acidosis, but this patient is alkalotic and we know she has a primary respiratory alkalosis. Therefore, the bicarb is trying to push us back in the opposite direction to correct for that. This is a respiratory alkalosis with metabolic compensation. This is commonly seen in salicylate poisoning, and sometimes we need to alkalinize the urine to help eliminate the potassium, the salicylate. But remember, this may produce low potassium levels. And finally, we have a patient who suffered a cardiac arrest but now has spontaneous return of circulation. His pH is very low, he's clearly acidotic. The PCO2 is high, that fits with a respiratory acidosis. But the bicarb is low, and that fits with a metabolic acidosis. And yes, we can have a mixed picture like this, both a respiratory and a metabolic acidosis. The reason for this in the cardiac arrest patient is because when we are providing artificial ventilation, it's not as efficient as our own breathing, so we get respiratory acidosis. And in terms of the metabolic component, the patient has been hypoxic and underperfused, leading to a metabolic acidosis. So in conclusion, this simple systematic approach can help you analyze blood gases. Thank you.